Now we start. Welcome to first international webinar in our head focusing dental technology. We have Louis Sharp in the room. We thank University of Cape Town for generously giving us this platform to use for this occasion. Louis Sharp has 42 years of experience in dental technology and has owned and operated his own dental lab for over 33 years. He has received advanced training in many areas, including Level 1 orognatic bioaesthetics, state-of-the-art aesthetics, in situ Institute for Advanced Dental Education, occlusion in clinical practice, the same institute, practice of excellence, the same institute, comprehensive approach to anterior aesthetics and function in a seminar by Matt Robert, Vident certificates for Sirona in-lab, InfoClub Fivadent advanced training for Sirona in-lab, Sirona in-lab advanced training module 1. You agree with me that today we're interacting with a well-experienced dental technician who has been in the field for so many years and still practicing. I leave you with Louis Sharp, who has about 45 minutes from now, though he has the liberty to exceed that time, to tell us about his topic, which is titled Predictable Result with Proper Planning. I leave you with Louis Sharp. Louis.
Thank you. It's a pleasure to be with you today. I hope you all can hear me okay. This is an opportunity for me that I appreciate. I love to share my knowledge and experience with other people, and I hope that the things that are presented today will be beneficial to you. They are things that I have learned over my years of experience and have benefited my laboratory. I think we're in the midst of a revolution in this industry, and it's exciting. It keeps me excited about the industry and what's happening. So I appreciate you being here, and I hope that you'll join in with any questions that you might have, and feel free to participate with me. As we begin, I thought what I would do is I would just like to kind of introduce myself. As was mentioned, I have a number of years experience in this field, and I do what I do because of the people pictured in the picture above. That's my family, and they're probably the dearest thing to me, and I'm grateful that I've been able to be a part of their lives, and that's the reason why I do what I do, and probably why you do as well as trying to make patients happy and make the doctors that we work with happy so that we can improve the quality of life that they have. I also wanted to tell you just a little bit about where my laboratory is located. As you can see here on the screen, you can see Las Vegas on the map. I think everyone knows where Las Vegas, Nevada is. It's quite famous. What happens in Las Vegas stays in Las Vegas. That's their slogan. But I can tell you that's typically not the case. And my laboratory is located about 90 miles north of Las Vegas, as you can see on the map located there. I think they're asking me if I can make it louder, but I don't have an adjustment on my microphone. I'll just try to speak a little louder so that maybe you can hear me a little better. Let me know how it's working. Okay. Um, this is what the typical landscape looks like around where I'm at. It's desert, a lot of cactus and sagebrush, and we're also located close to what's called the extraterrestrial highway near Area 51. In fact, we're located 60 miles from Area 51, if you're familiar with where that is. That's supposedly where the alien bodies are kept and where they did a lot of nuclear testing in the early 50s. And so we're relatively close to that area. But there's also some beautiful areas in where I live, fed by natural springs and a lot of beautiful green trees, and it's a beautiful lush valley here where I live. A little bit about my laboratory. There's a picture here you can see in the top. That's my CAD/CAM scanning and designing area. As I've mentioned, I believe that there is a tremendous revolution going on. In fact, I believe you could call it a paradigm shift. I've been in the laboratory business for over 40 years, and typically the way that I always proceeded with cases and with the techniques that were done were through the lost wax process, where you would make something by hand, create it by hand, where you would invest it, burn it out, cast it, either apply metal or gold crowns, whatever you did, polish the gold crowns. That was the technique that was the standard in the industry. That's all changing. And even though we see a lot of CAD/CAM now, I believe it's going to become the norm. I believe that it's here to stay, and that we have to embrace it and learn it. And even though the software can do a lot, it still requires the knowledge of a technician, of proper tooth morphology, of proper aesthetic principles to get the best results that we can get. You see in the top I have a 3-shape scanner. I've just implemented the 3-shape software into my laboratory, and I also have a Sirona InLab that I've used for a number of years. In the bottom picture I have it's my 3D printer on the left. That's a new addition to my laboratory, and we're just trying to switch over to becoming completely digital. Instead of pouring models, we'd like to scan the impressions and print them with our 3D printer. We're beta testing that right now to see how well it works, and we're hoping that we can do most of our workflow in that manner. In the middle is our zirconia sintering furnace. The main one we use on the right is an older model of a zirconia sintering furnace that we still use as well. We do a lot of sintering. Most of what I do is zirconia and porcelain fused to zirconia, as well as Emax, and all ceramic restorations. I really don't do many porcelain fused to metal restorations at all anymore, and the gold crowns that I do now, I design and mill, send them out to a company in California that mills them for me. I was going to include a picture of a 4-unit gold bridge that I just recently did, and I didn't get it in my presentation, but it's amazing how the technology has changed. On the left in this picture is my 5-axis mill that I use to mill my zirconia, as well as other materials, PMMA material, wax material. It's an amazing machine. And on the right is a batch of printed models that just came out of the printer 3 days ago. As I mentioned, we're beta testing to see how that works, and the cases turned out really wonderful. It's great to be able to utilize that technology. Another very important part of my laboratory, and as I entitled this presentation, proper planning provides, predictable results with proper planning. Too many P's in there. Are my photography equipment. I purchased a camera, I don't remember how many years ago, but it's been a number of years ago, and it changed the way that I do dental technology. Typically I would get a prescription from a doctor, and I would have a crown that would need to be a shade A2, and that was the only information I had. And so I started trying to go to their offices and take pictures of restorations to better match the color. And I also started taking pictures of the restorations that I completed to critique my work and to look at my work and evaluate it and try to see where I could improve. And I would venture to guess that of all of the equipment that I've purchased in my laboratory that's been beneficial, a quality camera has probably been the best investment that I've ever made, because it did more to improve the quality of the work that I do than anything else. When you have an opportunity to actually create a tooth rather than to just match a shade tab, it changes the way you look at your restorations and the way that you do things. I started out with 35 millimeter camera with film, getting them developed. I went to a point and shoot camera. That worked fairly well, and graduated eventually to SLR camera, Canon. It's an older model, and I've got a macro lens and a ring flash that really provide high quality photos, not only of patients' shade matching, but also of the work that I do. And you can see there's a little light box here that these cameras are in. That's where I set up my cases to take final photos and to evaluate the things that I do. It's a very inexpensive, you don't have to spend a lot of money on things like that. You can actually do them very inexpensively. If you Google them, you can find ways to do light boxes very cheaply. And you can also find used cameras and lenses that make it very affordable to get into for digital photography. So if you have an opportunity and would like to do that, I would certainly recommend that you pursue that. It will change the way you do your work. So what I wanted to do is just take some cases from my laboratory and explain to you how I work with my doctors and how we try to come up with the best results possible for our patients. Sometimes we see a case like this and we look at what needs to be done. The doctor sends you the information, and in the past I've received impressions for cases like this that were already prepared, didn't have much information on them, and so I didn't feel like I was able to give them the best results that I could. But to be able to take a case like this and get the results, the best results that we can, it requires a process, and it requires a protocol that we need to follow. You can see here the patient had quite a bit of decay, was missing number 6. That was placed with an implant. This case was done by Dr. Saeed Motashimi in Las Vegas, Nevada. He's a very good dentist, excellent dentist and surgeon, and I've done a number of cases. Some of these cases are from him and the work that we've done together. So as I start out on this case, you can see in the top picture that that is the pre-op situation. That is a digital scan of the model, and I always do that as I begin a case, because I do my my mock-ups digitally, and I will go a little bit more into detail on that. But you can see in the upper, the pre-op situation. In the lower picture, you can see the digital design that that I did. This is using the Sirona software, and was able to make some temporaries, or actually this is the digital mock-up. I don't mill these out of wax. Typically this would be done, here again, kind of the paradigm shift. It would be done with wax and done by hand, and this is done in the software. This is milled out in a composite material, and then I just simply glue them on the model, and I use some techniques to provide surface anatomy and contouring, and then a glazing at the end that provides a really nice presentation for a digital or for a mock-up for a case. From that mock-up, the doctor provides a nice set of temporaries. You can see her full face shot here, the difference that it made, and the one on the right. I get information from the doctor after this stage. When I get the case back, I have after he has prepared the teeth, I have a model of the temporaries. I have instructions on particular lengths of teeth, whether they want a certain look or something longer or shorter or whatever the case may be. That information is transferred to me there. And then the time for the final preparations or for the final design. You can see here the implants in tooth number 5, or actually number 4, number 6, and number 13. I teased the doctor a little bit because he's right-handed, and you can see the preps lean a little bit to the left because he's right-handed. When he prepares the teeth, he has a tendency to kind of, it's almost like a signature in handwriting, and I've pointed that out to him before, and he never really realized that. And that's one of the reasons why it's important for transfer information so you don't have a canted midline when you finish cases like this. And I'll also provide information there later on in this presentation of how we can do that. So this is just simply a design, a cutback from the design. In the software, the full contour crowns are digitally cut back. You can see this is a full contour crown down here on number 4 and on number 13, and then we've got cutbacks on the 2 premolars as well as facial cutbacks on the anterior teeth. And then this is the final ceramics that I did for this case. Obviously taking the temporary length and the contour and design of the temporaries, then after sintering the zirconia frameworks, layering the porcelain on top of it. This is Noritake CZR Caribbean porcelain. I think that's how it's pronounced, but it's a very nice aesthetic porcelain, and you get some really nice results from this material. Here's just a little different shot of that particular case. You can see some of the incisal translucency and effects that are in this case, as well as from the lingual aspect, some of the morphology and just the way that the case turned out. And that's the final results. You can see the first pre-op picture on the left and the final picture on the right. As you can imagine, the patient was very happy, and what a smile. It just made such a difference for her. It changed her life, and it's that kind of feedback and that kind of smile that I love to see, and part of the reason why I do what I do as far as the cases that we work on and why we work so hard to make them look nice. So this next case, I wanted to just basically start at the beginning, and I'm going to go through step by step on how we make this work. This is a patient that just wasn't happy with, she had a temporary bridge here. She wasn't happy with the shape and color of her teeth, and she had come to the doctor and wanted him to give her a more aesthetic smile. Of course, I have to admit that I live close to Las Vegas, Nevada, and a lot of these patients in the area like white teeth. And so a lot of what we do is cosmetics. Cosmetic dentistry is a very subjective term. What's cosmetic dentistry to one person may not be cosmetic dentistry to another. I look at some cases that technicians do that are incredible, that look like normal, natural, healthy teeth. I look at some, even these cases of mine that are more white and lighter that a lot of people consider cosmetic dentistry. So it's subjective. It depends on what cosmetic dentistry is to you, I guess, or to the practitioner. But we fill a prescription and we try to provide the doctor what he wants. And so that's basically what he considers cosmetic dentistry is what we try to provide. So you can see here the pre-op situation as well as the diagnostic mock-up for this case. It's very important with these stone models, the impressions that we get as I mount these into the bite and try to provide not only the aesthetic, kind of predict how this patient can look, but also function as well so that they function properly. You can see we're also going to be doing a couple of implant crowns on the lower, but this is her upper 12 teeth actually. And so information that I receive here is critical. From the wax up that I do, or the mock-up that I do, I provide the doctor with what's called a silicone stent, and this is what we use to do what's called the shrink wrap technique for temporaries. As you can see, the mock-up is here on the left, as well as a silicone stent that I made by just putting the silicone putty over the teeth, and I actually put it in a pressure pot after I put it on the teeth and let it set up. I take it off and just trim it so that it's not terribly bulky. I mark the midline, and then in the office they take the model of the wax up and they Vaseline it. They put Vaseline over the teeth and on the model everywhere that that this stent is going to be touching, and they take a light body impression material and inject it into the silicone stent. You can see that it's done all around the anterior teeth on that lower picture. And what that does is it provides a very accurate duplication of the mock-up. Now they do have to go in, you have to go in and cut and trim in the interproximal embrasures to make it so that that stent fits in the mouth very easily, that you don't have any flash in those areas. So you have to be careful and trim around some of those areas to make sure that you get a nice clean representation when you put this in the mouth. So with this next slide, you can see here that in the upper left-hand corner, the preparations were done. She's missing number 9. We're doing a bridge there from number 8 to 10. And you can see in the lower picture, that picture with the doctor's gloves in the photo, that was immediately after removing the silicone stent from the patient's mouth. So he injects the impression material after the preparations. He injects the impression material, or the temporary material, into the silicone stent, places it in the mouth and lets it set for about 1 minute and 30 seconds. At that time he removes it and takes an instrument and just removes the flash from around the teeth that might be protruding from the impression or from the stent. It's still pliable and workable, so it's very easy to just pick off and remove. After he evaluates the temporaries, he might go in with a fine diamond and contour around the tissue to make sure that the temporaries don't impinge on the tissue too much, which can open up those areas and cause you to have black triangles when you do the finished restoration. So tissue management's a very important part, and these temporaries, if properly done, manage the tissue very well. In the right-hand photo, you see a device that he uses. I think it's called a face aligner. You can actually do this with actually a wooden Q-tip if you don't have access to these aligners. That particular aligner has a tray, a flat tray that fits in the patient's mouth. They just inject some Blue Moose bite material onto that tray, place it in the mouth, and align all of those, the two sticks with the patient's midline, the facial midline, and with the interpupillary line. And it provides an accurate way. If we go back, as I mentioned earlier, if we look at these preps, and you mounted that on the bench without some kind of guide, you could end up with a canted midline and with something that isn't aligned properly with the patient's face. And so this particular device provides a way for us to transfer that information. As you can see in this slide, her facial midline and her interpupillary line give us the vertical and horizontal dimensions that we need to mount this case on an articulator and have the restorations on a proper plane in her mouth. You can see that they're mounted according to the face or the incisal pin on the articulator, and everything lines up. If it lines up in her mouth, lines up on the articulator, then you're going to get the same results when you finish the case. So these are the temporaries that he made and that were finished at the time of the preparation. She comes back, typically he has the patients wear these temporaries for a week and then come back and talk about size and shape and color and things that they like and don't like about their temporaries, so that when he sends the final impressions to my laboratory, we know exactly what the patient is looking for and how we can best duplicate that. One of the things that you notice in this particular picture is the tissue line on number 7 is a little low. And that's one of the things that we wanted to correct in the final restorations, is to be able to make that tissue line more even for this patient. And as we get there, you'll see we were able to do that. So this is a slide of the scan of the preparations. And then you can see the bottom slide is a scan of the temporary model that was taken by the doctor at the time that the temporaries were approved. This model is scanned and can be in the Sirona software. You can do this with various other softwares as well. It's merged into the software so that as you're designing the case, you can either duplicate these directly or you can use it as a guide in creating the new restoration, so that you maintain the same incisal position, you maintain the same incisal length and basic width of the teeth, because you had received approval for the preparations or for the temporaries, and that's where we want to end up with the final restorations. So in this picture you can see the final ceramics for this patient. The photographs on the left, that's done by me. All of the benchtop photography is done by me. You can see the final results that she has in the mouth. She has such an infectious smile that it's amazing. Let me move this down a little bit if I can. I don't know if I can on my screen anyway. As you can see, the tissue levels are where we want them to be, and she was really happy about that. She looks very nice. The smile that she has now is really quite nice. So here we see that we've gone from the pre-op condition to her temporary crowns to her final ceramics, and she was really pleased with the final results that we got. If anybody has any questions or anything so far, please let me know. I don't know if I'm going too fast. I hope everyone can hear okay, but as I mentioned, just pipe in anytime you want to ask a question. The next part that I thought I would just go over briefly, this is a really simple technique that you can use to provide or to produce really quite aesthetic results in your porcelain buildups. There's a lot more sophisticated and complicated ways that you can layer porcelain, and I use some of those in different cases, but this is a very simple buildup technique that can provide really nice results for final restorations, and I'll show you the results that we get from using this technique and this particular porcelain. This case, once again, is a porcelain fused to zirconia case. Crown number 5 or number 4, let's see, no, number 5 is a full contour zirconia crown. I think it had an incisal cutback maybe and some incisal porcelain, but basically we were going to layer the anterior 6 crowns with a zirconia lingual to try to protect the lingual surface and protect the porcelain from chipping. So after I build up the porcelain, I build it up in a full body buildup to mimic what we want to do from the temporary model that we have. You can even use an incisal guide if you need to, where you take an incisal, some putty, and take a guide of the incisal edge of your temporary model. This particular case, I just took the body porcelain and I used a porcelain sculpting knife to cut back in the interproximals, to cut back on the incisal to leave a little bit of body porcelain up where the mamelon structures would be. As you can see, it's not even, it's not precise, it's kind of uneven and jagged, and that's really kind of what I want. There's also areas that the zirconia was kind of showing through, so I just go in and add a little bit of body porcelain to those areas so that I don't have a kind of a show-through effect with the zirconia, even though it's pretty aesthetic for a framework material. You can still have that show-through at times when you're thin on some of these areas. So after I cut back the body buildup, I go in with a couple of different porcelains that I use with the CZR line of porcelains. I'm trying to move this video out of my way, but I can't get it out of my way. Okay, so you can see here that I use mamelon porcelain in the areas of the mamelon structure on the cutback. I use some transparent blue porcelain. This is with the CZR line. And I use, that's a pretty simple basic layering technique. I go through and layer the translucent blue or transparent blue next to the mamelon structures so that it kind of helps highlight those. And then I just go in, I'll use some clear incisal. As you can see on the incisal edge, I'll use just regular incisal porcelain to finish the buildup all the way around, and then I do my first body bake after I do the buildup. You can see in the top, come back for the correction bake. There's always modifications. I do some preliminary shaping and grinding and look at contours and see where we need to add the contours, maybe where we need to create some better contours. So I go in with a clear incisal on the incisal edges to do any corrections and overlay over the excuse me, over the labial surfaces and also down around the cervical portions. That's just regular body porcelain. Like I say, this is a very simple technique, very basic technique, but it really produces very good results. You can see in the bottom picture that is this very case. That's in the mouth. And the incisal effects are really quite subtle. which in this case, that's what we wanted. We didn't want really definite mamelon structure to be showing through the incisal, or very clear incisal porcelain or incisal edges. Those teeth look quite natural and came out really quite nice. This is the lady that we did this case on. She was not happy with the arrangement of her anterior teeth and was missing some teeth, so she decided she wanted to have her anterior teeth done so that she could have a nicer smile. And so we went through the same procedure. We did a digital mock-up on her. The anterior 6 teeth are shown here, and you can see in this slide some of the nice surface texture and labial anatomy that you're able to put in this material that I use for these mock-ups. The lower picture is of the temporaries, the shrink-wrap temporaries. And one of the things that I noticed from this picture was that there's a bit of a cant, if you can see here, and some tooth arrangement that need to be fixed. Now, I don't know if there are times that the dentist doesn't get the stent quite properly placed, or whether sometimes it's just because that's the way they're fabricated, but we see these changes that need to be made, and that's part of the reason why we go through this process. If these were the final ceramics that we had provided for the patient, I don't know whether I would be real happy accepting those with the form that they are. She was happy with the temporaries because it was quite an improvement from what she had, but we made some changes from the temporaries to the final ceramics, and this is the final ceramics. As you can see here again, the incisal edges, it's quite subtle. This is the same buildup that you saw earlier in the slides. And here once again is the final restorations in the mouth, and a couple of lateral views as well. And this is the patient with the final restorations in place. She was really pleased with her treatment. This particular doctor has a patient appreciation night once or twice a year, and he invites these patients. He does a lot of cosmetic restorations. He does a lot of all-on-4 complete rehabilitation and full implant cases, and he changes these patients' lives every day. And he has a patient appreciation night where they come, and he has a photographer there that does professional photographs of them and their final smiles, and it's very popular with the patients. And this is a picture from her photo shoot that she had done, and very beautiful woman, and it turned out really nice. You can see the before and after here, and the changes that were made, and what a difference it made in her smile. This next case is just kind of finishing up here with a few things. This case that I'm showing you here is one that presented to the doctor that had some obviously space issues, diastemas between his front teeth. He wanted to close those spaces and get a more natural, nice smile. So the doctor, the instructions that came with the case was to close the diastemas. He wanted to correct the edge-to-edge bite and try to do more of a class 1 type of occlusion, make them slightly longer, and keep good proportions on the teeth so that it doesn't look like you've got huge centrals and small laterals, but to try to maintain good proportions. And he didn't want it to look bucktooth. Now you can see this is quite a challenge because there's quite a space between number 9 and 10, and without using this type of protocol in these cases, I think it would be very difficult to get the results that you want. But because we go through step by step and evaluate, we're able to provide the patient and the doctor with the best results. So here's the transfer you can see. This is the temporaries that I made that were milled out of the acrylic block. And on the right you see the temporaries that are the wax-up, mock-up on the model that was sent to the doctor before the final preparation. So the phase 2 of this treatment, the doctor prepared the teeth, used the temporary stent that we gave him, and trying to maintain all of those the things that he had indicated that the patient wanted. We took a look at it in the temporaries. You can see on the bottom, that's what he looked like in the temporary restorations, and the patient was pleased with that. Very nice symmetrical smile, and the final phase, phase 3 was basically, as you can see, the final ceramic restorations that we did. And once again, I just used a simple incisal layering technique on those, and tried to follow the guidelines from the temporaries, from the model that we received from the temporary impression, and that was the final results that we had there. He was extremely pleased as well. You can see here, this is the final face shot. That's the final smile shot that he has, both with the lip in the picture and retracted. And you can see the results that we were able to achieve. So that's about the length of my presentation. I have a lot of information that we've gone through, and I didn't go into depth in a lot of the procedures, but I hope I gave you enough information that can help you either improve what you do, or look to sources that you can find that can use these techniques, but they're proven to be effective, and they are proven to provide excellent results for the doctor and the patient. So I'm really pleased to be able to present to you today, and I'll take any questions that you might have, or if I can answer any questions, I'd be happy to. You can see my contact information. Please feel free to contact me. I'll be happy to answer questions and do anything I can to provide information for you. I also have a Facebook page that has quite a few more of our cases there, and you can go there and like us, or comment on there, whatever you'd like to do, but I'm happy to help out. So I'm grateful for this opportunity. I'm grateful for Olufemi and for inviting me to do this, and hope it's been beneficial for you.
Oh, Luis, you've been very wonderful. You have really enlightened us in a most special way. We have been able to see the paradigm shift, and we are happy that you are being in the field. Most of the participants today will be engaging with some of the things you said today for the first time, and there's no doubt it is one of the best opportunities that anyone could have. I have some questions, but rather than ask questions now, I will give the opportunity to any of the participants who has questions to throw their question at you before I do mine, so that within a short while from now we could round up and finish. So Oscar, do you have any question for Luis Sharp? I can give you the microphone if you can speak, or you type in your question in the box so that Luis Sharp can read and respond to your question. Okay. Omatayo, you want to speak? In case you can, I will give you the microphone now. Okay. I'll give you the microphone to. Yeah, Amata, you can speak now. I have enabled the microphone for you. Anyone who has interest of asking question and has access to mic, I will give you access to speak to Louis Sharp so that you could take your question. But in the event you cannot do that,
hello, sir.
Please just type in the box so that we can.
Okay.
Louis Sharp will read through
Okay.
and be able to attend to your question. I will adjust my mic. NDBC, I hope it's better
Hello,
now.
sir.
I've adjusted the mic.
Can you hear me now?
Yes.
Okay.
Yeah, I hear you. Yeah, beautiful. We can
All
hear
right.
you, and I
My
believe
question is on the transfer of photographs, patients' photographs to the laboratory. And the question I want to ask is the relationship between the clinicians and the laboratories in the taking of photographs and then the transferring of those photographs to laboratory practices in order to achieve a better aesthetics. Can you throw light on the relationship between the clinicians and laboratory technologists and how they achieve that?
That's an excellent question. You have to have a practitioner who is willing to obviously participate in that. And what we do is he transfers that information to me via email, and I receive that information, and as well as the prescription form that he has transfers that information. But it's simply a matter of he takes the photographs. He usually, in many cases, will include a shade tab in the photograph or a couple of shade tabs based on what we're doing. If it's like a full anterior case and we're not trying to match one single central, then he'll just put a general shade tab. But if it's trying to match a single anterior tooth, many times he'll put a couple of different shade tabs in the photograph. But then he just emails them to me, and I just keep them in a file for that patient. But it has to be encouraged on the clinician's end.
Okay, sir. Thank you very much. That was very good, sir.
Thank you.
I'm so grateful.
Thank you.
Yeah.
If anyone is interested, I can, if you want to email me, there's a link on, I'm trying to think, I was going to put it in my presentation, but I couldn't find it in time to get the information to Olufemi. But there's an online course in intraoral photography that was very helpful, and I could get you that information if you were interested. Just simply email me, and I can provide you with a link to that information.
Yeah, thank you very much, sir. We are very much interested in that. That's the intraoral photography, an online course, right? Hello?
Yes.
Yeah, we're very much interested in that. I'll communicate you on your mail, sir. Yeah, I'm a technician from Nigeria. I'm a technologist from Lagos University Teaching Hospital.
Wonderful.
Yeah, so I'll be very much interested in that course, that online course. So I'll appreciate if you can, well, I'll communicate you through your mail. I can see your mail on the screen. So I'll communicate you, sir, for more information on that.
Please do.
Yeah, thank you very much.
Any other questions? Jakub, you have a question?
If you are hearing me, you can, you can speak now if you have a question. Shinelo, you can speak now if you have a question. Kisley, now you can speak now if you have a question. The speaker, the microphone has been given to you. Okay, but if it is not possible, you can place it in the box so that we can see, and Ms. Sharp will attend to your question. Yeah, we can hear some background noise there. Yeah.
Hello, good evening.
Yeah. You can ask your question. Ayodiji, you can ask your question. I can see that you are trying to speak.
All right, good evening, sir. So I want to have Sharona.
The voice is gone.
Yes.
You want to ask about Sirona, Ayodeji?
Yes. Go ahead.
Please go ahead and ask your question. Okay, I think the video will be sent to you. The video link will be sent to you as soon as it is ready. Don't bother. I'll get it across to you. Okay, Luis Sharp. One of the participants want to ask question about Sirona software. I don't know what question that question is, but we couldn't hear him. Ayodeji, can you type the question there in the box so that Luis Sharp can treat it? Hello, Phillips. Phillips, can you hear me? Okay. Luis, I think we're having issue with internet, and unfortunately we couldn't hear questions. But I think you would like to maybe say a little more about Sirona there, so that Samuel, who made effort to ask this question, could hear you a little more about Sirona.
Sure. I started out with the Sirona InLab probably 11 or 12 years ago. I started with a red cam and graduated to a blue cam, and I've been using their software that's been upgraded now. They're at version 16.1, I believe. So it's very nice software. It's very user-friendly. I use both, as I mentioned, I have both Sirona in my laboratory and 3Shape. The Sirona also provides the Sirona Connect aspect with allows doctors to send digital impressions through the Sirona Connect portal directly to me, and I can open them up in my software and design and fabricate the restorations and print the models. Of course, any major dental software program now, 3Shape, exocad, I've used all of them. They provide the same thing, some kind of portal for the doctors to send you intraoral impressions. But Strata is it's a nice company. It's a great company to work with, and the software is it's very user friendly and works very well.
Okay, I think that is very explanatory. We can see Michael typing in the box. Maybe he's composing a question for you. Be proud to getting his question.
Okay.
Let me say this. I discovered some of the worst work that you presented to us. I discovered they are white in color. In Nigeria here, we haven't seen, I personally haven't seen white was. So I'm wondering whether I'm getting it rightly or not. And again, I would like you to talk about throughout your presentation about setup, you didn't mention the use of articulator. I was now wondering whether you don't include that when you needed to set up with was and all that, whether you don't use articulator. In case you use, can you explain a little bit to us about where articulator gets involved with your work? Thirdly, the lady you change her aesthetics there in one of your slides shows a great job and an excellent job for that matter. I wish if you can explain a little bit about that, because I see that the teeth didn't show very well why when she came to the lab, but later when she was leaving, the whole thing showed very brightly. I mean, we can see more
Sure.
of her anterior
Use of
teeth.
articulators. The
Please,
first
can you say a little bit about
I
that so that
use
we
a
can
Stratos
get a picture of how you achieve it?
articulator, and I typically just for the cases that I've done with this doctor, I just receive bite registrations. I'll receive a centric and a centric bite, and he doesn't really do a face bow registration, but I mount all of the cases on a Stratos articulator using the transfer, the aligner that I showed you in the slides. One of the reasons that that this particular procedure makes it so predictable is they wear the temporaries for a while, and if there's any problems with the occlusion or any things that interfere, that's all worked out in the temporaries before we proceed to the final ceramics. So we're basically trying not to interfere with the patient's normal paths of excursion. We're trying not to interfere with their envelope of function so that they don't damage the restorations. And that's simply what I use. Is I use the a semi-adjustable articulator. I also use a SAM articulator, depending on the doctor and depending on the registrations and the information that they give me. As far as the second question, I'm not sure I understand what you were asking about the patient, what we were achieving.
Yeah, I thought maybe I didn't get that aspect of how you achieve that aesthetics, that the anterior teeth could show brightly and better than when she came in. I missed that portion of your presentation, and I don't know if you can just
a lot of the
help
shades
explain a little
that I
bit about
do
it,
for
how you achieve that aesthetics.
cosmetic patients, as I mentioned, the city of Las Vegas is a very kind of a Hollywood smile type of an area. So cosmetic dentistry to them is usually whiter and brighter, and so some of these patients, they feel like their teeth look yellow and dingy, and they want to brighten their smile. So a lot of the shades that you see in the photos are probably about a bleach shade, either 020 or 030 on the, I think it's the Ivoclar shade guide. And so that's basically, with some incisor layering, that's how we get the, I think a lot of, to get the natural smile and to get the natural look, as I mentioned, I didn't go into depth in a lot of areas as far as facial contouring, as far as facial anatomy and texture, how to achieve a nice texture. Most of those restorations, I glaze with a artificial glaze in the furnace, and then I take a Edenta rubber wheel and kind of go through and buff the glaze down a bit, and then I take a Robinson brush and some Diashine polishing paste and buff them back to more of a natural gloss as opposed to a glassy oven glaze, and it gives a little bit more of a natural look to the tooth and a little more natural look to the surface anatomy that you placed in it. I hope that answers your question.
Yes, really. I got a better question, perspective to that. In the BC, we want to know how to start training, to get more training in zirconia techniques, veneering, or ceramics. He want to probably get suggestions
Michael, thank you
from
for participating
how
with us
he
today.
can
And I would
get
imagine the
trained
best
better
place
in
to
those
start,
areas, perhaps
it
short
depends on what
courses
kind
or
of
whatever.
access you have to CAD-CAM technology. That may be the biggest hindrance. You have to have some kind of access to be able to produce the zirconia frameworks. That's rarely only done through CAD-CAM technology. So I actually started with zirconia in my lab with a Zircon Zon machine that was basically a copy mill. And what it was you would make a resin pattern of whatever you wanted done in zirconia, place it in a holder, and the Zircon Zon machine had a handpiece in another holder that would cut a piece of zirconia as you move the pointer around the resin pattern that you made. I don't know if you can visualize that, but it's kind of the handmade version of CAD-CAM technology. And so, like I say, that's where I started with zirconia. That was years ago. And it's progressed a long way. So I don't know what kind of access you have to to that kind of, to be able to produce the zirconia frameworks, but that's really the best place to start. And from there, it's just a matter of learning layering techniques, using whatever type of porcelain you use. So if there's any way I could help with that, I'd be happy to do that.
Michael, I can see that you are typing in a box we have not received from you, maybe internet problem. However, if you are satisfied with that answer, can you use the tab of, okay. The question came, he said, what about veneer and all ceramics?
Are you talking about like veneering porcelain, or are you talking about, I'll address a couple of things. So what I use in my lab for veneers is typically Emax, Ivoclar Vivadent Emax, and all ceramics, that's typically, it'll either be a zirconia substructure or an Emax substructure, and I use the Ivoclar Vivadent Emax Ceram porcelain with the Emax system, and the Noritake CZR porcelain with the zirconia frameworks. Obviously with Emax, I don't know if you have the capabilities to press, but Emax can be pressed or milled, And so if you have a burnout furnace and a pressing furnace, you can fabricate the restoration, burn it out, and press it in a pressing furnace. So that's what I use for those particular restorations. I don't do a lot of pressing in my lab. I do mostly milling, but I know a lot of labs that do, even with the CAD/CAM technology, they will design and mill out the wax patterns and then invest the wax patterns from the mill and press them in the ceramic and the Emax. I see you typing another question.
Yes, I can see he's typing, and probably another question. We are on top of the hour already. We should be about finishing now. But let's give this chance, if Liz wouldn't mind, to Michael to say a last question, then we close this session. Yeah, his question, you can read it there. He said, are the machines for pressing very expensive? I think
relatively speaking, I think. Yeah, I think you can. In the States here, you're going to pay probably $6,000 to $8,000 for a pressing furnace, and so
68,000.
It's kind of expensive. 6,000 to 8,000. Yeah, so it's either 6,000, somewhere between the $6,000 to $8,000, 68,000. I'm sorry. But I don't know what pressing furnaces are available in your area of the of the world. Maybe there are companies that provide less expensive alternatives. You might check into that, and you can maybe even possibly find a used pressing furnace that would work for what you need, that would be less expensive.
Thank you, Liz Sharp. I think you've really spent some time with us today. I do appreciate your time. I do appreciate the fact that you are doing this free without any dime for your time. I'm also happy that the participants too who are attending this webinar free take out time to attend and grace this occasion. I believe they will maintain contact with you through the Gmail and your Facebook, and I believe too that you will be happy to speak with us in future. Maybe that time we'll be asking of hands-on. If it's convenient for you to have camera on and have hands-on so that you actually show us something, I think that would be beautiful. It is possible, and I believe that you may make out time in future for us to see from you how you actually perform a laboratory technique, a hands-on kind of approach, so that the young technologists who are here, because we are not called technicians in Nigeria, will be happy to listen to you. I appreciate you, and if there's anyone who wants to say a word of thank you to Louis Sharp, I'll give you mic that you can speak to him, or just type it in the box. Okay, Ebenezer said it is a pleasure that he will keep in touch. Michael said it is wonderful. I think that those are the kind words from participant to you, Louis Sharp. I wouldn't mind if you want to make a statement, final statement before we close the session.
Yeah, thank you. As I mentioned earlier, it's a pleasure for me to be here. I enjoy sharing knowledge with those that are interested in learning, and I'm happy to correspond with anyone that I can answer questions for or give information to. it's an interesting industry. I don't know how much different your industry is there than ours is here, but we have to keep finding things that keep us interested and keep us motivated and keep us excited about the work that we do. And I know for me, anytime I have an opportunity to go and learn from someone or see something that someone's doing, it motivates me and inspires me to be a better technician. So I hope that that we can all use that to improve what we do and provide better restorations for the patients that we serve. Thank you again.
Oh, thank you, Luis, for your time. You have spoken for close to... Okay, Michael want to raise his hand there. I know, sorry, let me... Oh, Michael, we may not be able to take your question. We can see that Michael is already, Luis is very stressed. So we will be going now, and we really appreciate your time with us. Thank you so much. I hope when we call you again, you will beckon again, you will answer us.
Thank you. Have a wonderful
Thank
day.
you, and bye for now.
Bye.
Bye. Yeah, thank you.